very clearly.
Okay, perfect. So, hello everyone, and welcome to today's session. In the last few weeks, I have been working with some of you on the practical skills such as survey tools, proposal writing, designing and conducting surveys, and even how to match research design to statistics. But today I want us to zoom out and think about research in a broader way, not just how we generate new data, but how we bring together all the data that already exists. And this is where systematic reviews and meta-analyses come in. These methods sit right at the top of the evidence pyramid, which we're going to discuss today. They don't just tell us what one study found, but they show us the bigger picture. And here is why this is important specifically for you. A systematic review can be at least a major part of a dissertation or a research project. It is a type of research that many students successfully complete for their dissertations or any type of research project at university, and it is often the foundation of future research projects. In fact, my own research journey began with a systematic review. I conducted a few systematic reviews on medications for Parkinson's disease, and I noticed that many clinical trial results were not being published at all or were incomplete, which meant that doctors and patients were missing out on important information. And this gap led me to explore knowledge of Parkinson's medications among patients and doctors, and later to my current work on shared decision making in Parkinson's disease. So you can see that systematic reviews don't just summarize what we know, but they can also reveal what we don't know, and that can open entire new research paths. So let's dive into today. So first, let's place today's topic in the bigger research journey. You have learned how to design your own research, especially surveys, which we focused on in multiple lectures here at AIU. You have worked on writing strong proposals, and you have started thinking about publishing. And now we're stepping into the territory of secondary research, synthesizing what is already published. This is the highest level of evidence in the research hierarchy. And if you ask why, it is because systematic reviews and meta-analyses do something that individual studies cannot do. They combine multiple studies into one coherent answer. And that means they are powerful tools, not just for academics, but also for policymakers, healthcare professionals, and anyone making evidence-based decisions. There are 4 key reasons that these systematic reviews matter. First, they are very comprehensive. A systematic review doesn't cherry pick studies, but it includes all relevant evidence. Secondly, they form the basis of clinical guidelines. If you have ever seen a guideline that says drug A is recommended over drug B, that conclusion often comes from a systematic review or meta-analysis. Thirdly, they highlight research gaps. As I already mentioned, when I did my Parkinson's review, the biggest gap I found was unpublished results, which was an ethical and scientific problem. And finally, systematic reviews save time. Busy doctors or policy leaders don't have time to go through hundreds of studies, but they can read one well-done systematic review and get a reliable summary. To date, I have published 4 systematic reviews and meta-analyses, and those are actually my top read research papers, even more than my original research. I also receive emails about my findings from other researchers, especially doctors. It is important to distinguish that not all reviews in the literature are systematic reviews, and not all reviews are the same. You have probably seen the term narrative review, which is a broad, like a story written by one expert. It can also sometimes be called a scoping review. These can be helpful for background, but they are more subjective. A systematic review is much stricter. It follows a set protocol, it uses transparent methods, and it aims to reduce bias. And then there is the meta-analysis, which is essentially a systematic review plus statistics, and it pulls numbers from different studies to produce an overall effect size. In other words, narrative reviews tell a story, systematic reviews build a map, and meta-analysis put a ruler on that map. I already mentioned the term evidence pyramid, and here you can see an example of one. And this pyramid actually shows why systematic reviews matter and why are they so important. At the base are small or less rigorous designs, such as case studies, cross-sectional surveys, which we have covered in previous lectures, and cohort studies. Then you can see come the randomized controlled trials, such as, for example, a clinical trial with a drug. They are stronger because they reduce bias, for example, by double blinding the participants and other randomization techniques. But even randomized controlled trials can be contradictory or too small to give us confidence. And at the very top, we find our systematic reviews and meta-analyses, which are the strongest evidence because they bring everything together. A systematic review is essentially a research project in its own right. We don't just read some papers and summarize them. There's actually a step-by-step process, much like in original research. First, we define a precise question, often using the PICO, P-I-C-O, which stands for population, intervention, comparator, and outcome framework. For example, in one of my reviews, the population was patients with Parkinson's disease. The intervention was the Parkinson's disease medication known as ND0612, which is actually a levodopa-carbidopa subcutaneous pump system. The comparator was a placebo, and the outcome was motor symptoms in the patients. We will still look at PICO in more detail on the next slide, but I just want to give you an overview. Based on this PICO criteria, I developed my search terms. This criteria serves as the inclusion criteria. And even if the criteria are not met, for example, the comparator was not a placebo, but another medication, then we would not include the study in our review. Then we develop and pre-register a protocol for systematic review, usually in a system known as Prospero. We further conduct a comprehensive literature search across multiple databases. This is where you use your search terms that you came up with as your inclusion criteria. I usually use PubMed, Embase, and Cochrane, but the databases differ if you're doing research in a different area. So I do clinical research, and this is why I use PubMed, which is already, as its name identifies, more for medical or clinical studies. But there are multiple of databases out there, and you can always find those appropriate for your area of research. After running searches in the databases, you will have hundreds, if not thousands, of studies. And then you screen the studies for inclusion criteria that you develop using the PICO framework and include only the ones that meet criteria and extract data for the outcome, assess the study quality using risk of bias tools, and then synthesize the evidence. We will also look at this in more detail in the next slides, so this is just an overview. And of course, the final step is reporting, where the most common framework used is PRISMA, known as the preferred reporting items for systematic reviews and meta-analyses, which sets out exactly how reviews should be written so they are transparent and reproducible. If you are interested, I can share a systematic review and meta-analysis that I have published so that you can see how I reported my results. Most of the time, it can be used as a template because most systematic reviews follow the same format. Clarity in the research question is everything for a systematic review, same as we learned in your original research when you're conducting a survey study, for example. The PICO framework makes your research question for the systematic review very concrete. For example, in Parkinson's disease research, a question might be in patients with Parkinson's disease, which is the population, does physiotherapy, which is the intervention, compared to no intervention, which is the comparator, improve motor outcomes, and that's the outcome. This level of specificity prevents the review from drifting or becoming biased, and without it, we would be tempted to include or exclude studies based on convenience or personal opinion. The literature search is the backbone of a systematic review. It must be exhaustive and reproducible. This means searching across multiple databases and not just relying on one. For example, I always search in 3 or 4. I do not just rely on PubMed. Importantly, we also look at gray literature, if possible, of course, such as dissertations, reports, and clinical trial registries. And this is done to minimize publication bias. Every keyword filter and Boolean operator must be documented so that anyone can replicate your search exactly. I usually put my search terms in the exact way as I search the databases in my appendix of the published paper. And this is the same as for original research. Your method should be always written in a way that if someone were to take them and do the systematic review again, they would be able to come up with exactly the same results. Once the search is complete, we move into screening. This is where inclusion and exclusion criteria are applied. For example, if we are only including randomized controlled trials in adults, we exclude observational studies or pediatric trials. If we want English language publications only, then we document that as well. So when you run your search, even though in your search you already were including using the Boolean operators, which is like and or, and you already try to include only your inclusion criteria, you will most likely still come up with other results. And that's exactly how it works. And this is why you do a screening afterwards to say which then of those studies you will actually include in your review and meta-analysis based on the specific inclusion criteria that you identified using PICO. And this step must be done systematically, often by two reviewers independently to minimize bias. Every inclusion or exclusion decision should be recorded, ideally in a database or a review management tool. To report this clearly, we use a Prisma flow diagram. This is the visual summary of how many records were identified, how many were excluded at each stage and for what reasons, and how many made it into the final review and essentially also the meta-analysis. It is a bit like the audit trail of your review, showing exactly how you arrived at your final set of studies. On this slide, you can see an example of my Prisma diagram from one of my systematic reviews. This helps the readers understand how many studies were there after your initial search. For example, for me, it was 266. And how many studies were excluded at each step of the screening. As you can see, already 17 were excluded just because there were duplicates. And further, I screened and excluded 235 because they did not meet my inclusion criteria. And then I had 14 reports actually retrieved and assessed for eligibility. So the screening is usually done with just the abstract. From the abstract of the study, you will be able to identify already if it's even relevant to you at all, because sometimes it will come up with searches that are not even relevant, for example, to your population or your intervention. And this is where that big number usually gets dropped. In this case, I dropped the 235. And the 9 that I assessed for eligibility, those were obtained in full text. And then only 8 were included in the review, from which only 5 had data in standardized format and could be included in meta-analysis. So not always will you be able to include all the studies in the statistical analysis in the meta-analysis, because some of them might lack outcomes in standardized formats. To do a meta-analysis, you need the outcomes to be in a standardized format, so they are the same across all the studies, and only then you can run a meta-analysis. For example, in the case when I look at motor outcomes, you could look at the UPDRS score, which is specific to Parkinson's patients. And the score needs to be then in mean difference, or at least report in that way that I can calculate the mean difference so that I can pull it together from those multiple studies and run a meta-analysis. If I'm not going to have a mean difference or a standardized mean difference from all the studies, then I am unable to pull them together for meta-analysis. After the screening comes actually data extraction. So this is where you systematically pull key information out of each study using a standardized form to keep things consistent. And at this stage, you will notice then how many studies you'll be able to include in your meta-analysis. So you might ask, what exactly do we extract? Well, usually it's the basics, starting with study design, population, intervention or exposure, comparator, outcomes, and the main results that you're looking for. We, of course, might also include things like funding sources, conflicts of interest, or follow-up duration, if that is relevant, maybe as a secondary aim for your systematic review. But for example, funding sources and conflicts of interest, I have never included in a systematic review, but follow-up duration might be important to look at, for example, how long the patients were followed up after receiving the drug and after being in the trial, and see if those results differ from the original ones in the trial. This is actually not a casual reading exercise, so it's structured and almost like filling in a spreadsheet. If you joined the previous lecture that I had on survey research, you saw how I coded survey data, survey results, and it has to be really structured. And it's the same way here. So you will use most likely an Excel sheet, and you will nicely put in all the data in the standardized format so you can read it and you can use it, and so that it makes sense to you yourself as well. There are also softwares known as Covidence or Rayan, which can help automate some of this process. And there are also tools like EndNote that manage your references, especially if you're conducting a systematic review where you're essentially including maybe hundreds of studies, even in the final stage. Personally, I like to do the review process manually because I am not keen on using these softwares. My university has a license for Covidence, but I have to admit that I do not find it easy to use, at least at this stage of its development. And I think that my manual process is more time efficient for myself. This, of course, is a personal preference, and the more important thing is consistency. Every study is extracted using the same template so that the final synthesis is reliable. Also, as already mentioned, not all studies are created equally. So a small, poorly designed trial should not carry the same weight as a large and well-conducted one. This is why systematic reviews always include a risk of bias assessment. For this, you have several tools. For example, I most commonly use the Cochrane Risk of Bias 2 tool, which is used for randomized trials, because that has been what I have usually included in my systematic reviews. And it asks questions about randomization, allocation, concealment, blinding, attrition, and selective reporting. For observational studies, you may use another tool, for example, a Newcastle Ottawa scale. And there are actually much more out there. You just need to search which one you prefer more and which one you think is appropriate for your study design. In my own Parkinson's reviews, one major problem I found was selective reporting, where only certain outcomes were published, while some results may have remained unpublished or incomplete. This creates a skewed picture and is exactly why critical appraisal is so vital. And without it, the meta-analysis can give a misleading pooled answer. You might ask, what exactly is a meta-analysis? At its core, it's just the statistical pooling of results from multiple studies. Instead of just saying 3 studies showed a benefit and 2 did not, we actually combine the numbers to calculate an overall effect size. And this is where it goes beyond just a systematic review. So in the systematic review, in the narrative form of reporting the results, so when you're writing it out, you might say in this way that 3 studies showed a benefit, whereas 2 didn't. But then we take it one step further when we actually statistically calculate an overall effect size and show the numbers, so how big and how significant the effect size actually was. This is powerful because it increases statistical power and precision. A single small trial may be inconclusive, but when combined with 5 others, then the picture becomes much clearer. For instance, if one trial of a new Parkinson's drug shows a modest effect, but it's not statistically significant, then a meta-analysis across multiple trials might reveal that the effect is real and consistent. So we cannot just look at one study, because also, as I mentioned, there might be a smaller sample size or some other reason why we can not trust that. So let's go deeper into how meta-analysis actually work. First, we need effect sizes. For binary outcomes like treatment success versus failure, we might use odds ratios or risk ratios. So you've probably heard of these. For continuous outcomes like symptom scores, in my case, it was motor symptoms for Parkinson's, we use mean differences because let's say you had a motor symptom score of 3, and after the treatment, it was 1. So your mean difference is -2 because it went from 3 to 1. If different studies use different scales, then we standardize them into a standardized mean difference. And again, this is important so that you can run the meta-analysis that you have this one form. So you can always standardize them if you have different scales for the mean difference. Second, the statistical model matters. A fixed effect model assumes all studies are estimating the exact same effect. And a random effect model, which is more common in health research, assumes the true effect varies between studies, which is realistic because studies often differ in populations, settings, or methods. And third, we must assess heterogeneity. You might have heard of this term as well. And it means how much the study results differ from each other. This is why we call it heterogeneity. And this is often measured with an I-squared statistic. And an I-squared close to 0 means that the studies are very consistent, whereas an I-square above 75% suggests substantial differences that make the pooling less reliable. Understanding heterogeneity is critical because a meta-analysis with high heterogeneity must be interpreted with caution. Here I'm showing you another practical example. Here you can see a forest plot, and this is the classic way of presenting meta-analysis results. Here we see an example of a forest plot from my study, and let's take a moment to interpret it carefully. I also want to mention that this forest plot was generated using Stata, which is a statistical software system, and I like using it for my meta-analyses because, as you can see, it immediately gives me a nice figure that I can use in my publication. So on the left side, you see the list of studies included in the analysis. So for example, Paula et al. 2007, Pfeiffer et al. 2007, Dewey et al. 2001, and Nomoto et al. 2015. I have named them accordingly, and I have also the references in the bracket so that people know which study I'm referring to. On the right, we see the effect size of each study with its 95% confidence interval. For example, the Dewey et al., so the third one in the line, had an effect size of about -23.8, with a very narrow confidence interval from 24.99 to -22.61. That study also carried the largest weight in the analysis, almost 40%, meaning that it had the most influence on the pooled result, usually because of its sample size or precision. Each study is represented by the blue square and a horizontal line, so like you see in this forest plot. The square shows the point estimate, and the line shows the confidence interval, like I just mentioned. You can notice how some intervals are wider. For example, Nomoto et al. 2015, which means that greater uncertainty is present in that study. At the bottom, we see a green diamond, which represents the pooled overall effect size across all the studies. So that's basically our meta-analysis result. Here, the overall effect is about -19.1, with a confidence interval between -25.5 to -12.7. Since the entire diamond is well to the left of 0, so you can see that it's very much moved to the left, this indicates a statistically significant effect that favors the treatment. And as you can see, Stata has this opportunity to also add these labels. So I have added the favors treatment in green and favors control in red. And in my case, you can see the diamond is clearly on the favors the treatment side, which means that we had a statistically significant difference of favoring the treatment, meaning that the motor symptoms were improved by the treatment much more than by the control. And since all studies and the pooled diamond are clearly on the treatment side, then we can conclude that the intervention was more effective than the control. And this is why in these systematic reviews and meta-analyses, you will often see these conclusions drawn and said that we can say that this treatment is more effective. Finally, notice the heterogeneity statistics. So on the bottom there where it says overall, there is the I-squared value. In this case, it's 67.93%, which tells us that there is substantial variability between the studies. That means that while the overall effect is significant, we should still be cautious because the studies aren't perfectly consistent. And the p-value for heterogeneity is 0.02, again, confirming that variability is more than we would expect by chance. So either it is because maybe the very big sample differences caused different results, but we can see that these results are very substantially variable between the studies that are included in our meta-analysis. So if we summarize what we just saw on this slide, then all included studies favored the treatment. The pooled results strongly favored treatment with high precision. One study carried more weight than the others, but heterogeneity is moderate to high, meaning that the studies are not perfectly aligned. And this kind of critical reading is exactly how you interpret a forest plot in practice, especially when you have run the meta-analysis and you're looking at the forest plot and you're reporting your results for your publication. So it's important that you know what you're doing and you know how to interpret this forest plot. One big issue in meta-analysis is publication bias. Small studies with negative results are often never published, while positive studies are, and this can distort the evidence base. A funnel plot, as you can see on the slide, helps detect this publication bias. In these examples, A and B, you see that each dot is a study plotted by size against effect. In theory, if there's no bias, then the dots form a symmetrical funnel, more like on the A side, so on the left side of the plot here. And if the funnel looks asymmetrical, like on the right side in plot B, then you can see that the left side of the plot is missing dots on the bottom. So it's not symmetrical anymore. Like there's this big white gap there on the left side of the plot B. And this suggests that there are missing studies, and often those are the unpublished ones. In my Parkinson's medication reviews, funnel plot asymmetry was a recurring problem, and this meant that the published literature probably overestimated drug benefits, which has real consequences for patients and doctors that try to make treatment decisions. So this is this thing that I saw with the gap in the research that we have these unpublished results. And I saw this in the funnel plots, and I knew that there's a lot of selective reporting in these clinical trials for Parkinson's disease. Of course, systematic reviews and meta-analyses are not perfect. There are several challenges that you must keep in mind. Firstly, what we just discussed, the publication bias. Second, poor study quality. If the underlying studies are weak, your review will also be weak. And this is sometimes known as garbage in, garbage out. So if you're going to include poor studies, known as garbage studies, then you're also going to get garbage for your systematic review. Third, there is selective reporting. Again, what I mentioned, that outcomes are sometimes cherry-picked, and you may not even know what is missing because clinical trials and even in other areas of research, there's often a lot of selective reporting where we want to, in those randomized controlled trials, to publish the results that we think are better for us because they are good results. And maybe some negative results, we just, let's say, push it under the carpet so that they don't go out there. And unfortunately, it's a big problem in research, which we are trying to avoid, but it still happens. So there's not enough transparency. Fourth, heterogeneity. So when studies are too different from each other, then pooling them may not make any sense because they're just so variable that even if we pool together, any effects that we make, any conclusions we draw, they might not be conclusive at all because the studies just differ too much from each other to be analyzed statistically together. And finally, we have the problem of predatory journals. I think I mentioned predatory journals to you when we talked about original research, survey research. And these are increasing in number, unfortunately, and they publish low quality or even fake research that can contaminate your evidence base. This means that reviewers must always be vigilant. And in this case, predatory journal can come into play twice. So first of all, if any of randomized controlled trials or any studies, even observational, that you are including in your systematic review and meta-analysis were published in predatory journals, it might mean that some low quality research that maybe wouldn't have been published if there was no predatory journals out there. Secondly, it comes into play when you want to publish your systematic review. This is a mistake that a lot of students make in the beginning, and I wasn't taught much about predatory journals as well. I had to learn it on a base when I was already doing research and publishing. But unfortunately, a lot of students fall for it because predatory journals look good. They promise you that they will publish your research, and often for maybe a smaller price to pay for publishing, or they will say that there will be a rapid peer review process and you'll get your article published within a week. So those are all signs of predatory journals that you should avoid, because maybe if you want to publish your research in a good journal, they will come back with better feedback for you and say, for example, we think that your review right now is weak, maybe you should redo it. Maybe there are other issues with the review, but predatory journal might just publish it the way you wrote it, and that is not good. So you should always aim for a better journal and take the criticism rather than just go and take the easy way out and publish your research in a not so good predatory journal. Also, systematic reviews carry important ethical responsibilities. Again, similar to our survey research or original research. There, we had to make sure that we are not coercing the participants, that we are getting their consent to participate. But for systematic reviews, a number one ethical responsibility is transparency, and transparency is not negotiable. So every step must be documented. And reproducibility means another researcher should be able to follow your methods and arrive at the same result. Of course, for systematic reviews, it is complicated to say that it will be exactly reproducible. That may not be the case, because at the time you conduct your systematic review, you will be including a certain amount of studies that have been published to date. So let's say randomized controlled trials in the last 10 years. But if somebody is going to try to do the same review a year or even months from when you did it, there will already be new studies out there. But of course, if they're going to put the exact same time frame that you used for your study, let's say till today, which is October 13th, 2025, if we're looking at all the trials that were published before that and we're including them in the review, then when somebody redoes it, even in the future, and filters their included studies up to October 13th of 2025, then they should be able to come up with the same results. Also, the pre-registration and the platform Prospero that I mentioned is increasingly expected. It's not a must, but I do encourage it, and I always do that for my systematic reviews. And this not only prevents selective reporting and duplication, but by registering your protocol, you commit upfront to what you will do, and nobody else can take your idea. So if somebody else wants to conduct a systematic review on the same, let's say, drug that you want to do, then they will not be able to if you have published your protocol on Prospero first, because you are out there saying, this will be my protocol. This is what I'm starting to do. It might take me several months or maybe a year to do it, but I will do it, and nobody else can touch my idea. So in a way, it's like securing it for yourself as well, not just showing of course, to future researchers that you thought about the step of setting a protocol, that you have taken ethical responsibility, but also it's a safeguard for yourself as a researcher. And finally, open data is encouraged whenever possible. So sharing your extraction tables or analytical code allows others to check and build on your work. And in today's research environment, reproducibility and openness are considered just as important as the results themselves. You don't have to put all your extraction tables and your analytical code in the publication, let's say. I, for example, like to include the search terms, which I think is important so people know what exactly I searched. But others don't even include that, but they just put a statement that you can reach me by email if you want to see my search terms, my extraction tables, and this is normal in a research environment. I have had multiple researchers reach out and ask me how I extracted the data, if I can show them the tables. maybe they want to check my work, but maybe they also just want to learn for their research. So this is in a way teamwork between researchers on the scale of research, and not just clinical research, not just medical research, it's also in social research. And that is a norm that you will probably also notice after you publish your first papers, that you will be contacted and asked to share your ideas or your research, or maybe even sometimes people will point out some mistakes that you've made, and that is completely normal and very human. And now if we just do a quick interactive formulation, I'm going to do this for you. So imagine we're planning a systematic review on the effects of mindfulness on stress reduction among university students, for example, like yourselves. First, we will want to structure this into the PICO question. So the population for us is university students. Intervention would be mindfulness programs. Comparator here would be no intervention or standard of care. And outcome is, of course, the stress levels in the students. And next, we must think about search terms. So we're going to touch on mindfulness, meditation, stress, anxiety, university, college. Those are the main ones, and you can still build around them. What I learned as a fresh student doing systematic reviews, what I thought was kind of reversed of what I thought in the beginning, was that the more search terms you're going to put down there, the more results you will come up with. I thought that the search terms usually narrow your search, but actually it's the opposite. So if you're going to put more search terms and more and or ors in between there, you're going to get a lot more results, and it's better for you. So you should always try to widen your search terms, because if you initially go through the screening stage of more studies, then you will be including more studies maybe at the end, and you will be showing that you looked at all the evidence out there and that you actually considered all the possible studies that you could have included in your search. And finally here, the inclusion criteria, which would be, let's say, randomized controlled trials, published in the last 10 years, human subjects, and written in English. So another really important thing is about when the literature was published. So a lot of times, for me, it didn't apply to many of my cases because I would be looking at drugs that were maybe came onto the market like 2 or 3 years ago. So the trials would not be older than 5 or 7 years. But sometimes you might be looking at older drugs, and then you have to think if you really want to include all the literature out there, or you're going to look at the last 10 years because those are more reliable. Maybe there was better medical devices and better reporting, like different guidelines came out, different clinical guidelines. So that's often a benchmark. We take the last 10 years. And that also narrows it down a little bit, so you don't have to go through a lot of trials that were, let's say, from the 1980s or something. Of course, also, it's important to identify what subjects. So if you don't say that you're looking at only human subjects, it might give you animal studies from preclinical research. So that's not something that you would need if you're looking at a population of, let's say, patients, and obviously want to see the motor symptoms. So you don't care about the motor symptoms being improved in the preclinical stage in animals because you want to see how this drug actually works in humans. And often the case here is that they're written in English, especially if you want to publish your research in an English-speaking journal, then you're going to be looking at the English trials, so you don't have to translate and something get lost in translation. If you want to do that, there's probably additional steps that need to be undertaken in regards to the ethical part. So they would probably ask, how did you translate the trials? So did you use an official translator? Did you use AI? Anything like that. But unless you can, prove that either you're native speaker then in both English and another language, then probably it's best to just stick into the literature that is written in English, so the people who read your review can also compare the original studies. And this formulation here shows how a clear framework makes the review manageable even before you start searching any databases. So this is the stage that you spend a lot of time on, and you should, because you actually define, so what is going to come up when I search it. And I've had, especially with my first systematic reviews, that I came up with my PICO question and my search terms, and I searched, and then I realized that I'm coming up with like a lot of data that is not relevant. So I had to go back and like change my inclusion criteria. That will happen when you're a fresh researcher, and not just fresh, you may be senior as well, and still make not even mistakes, but like not think it through maybe 100%. And that's all what research is about, that we go, we try, and then we come back and we look at those different steps and we try to improve. So it's normal to do that. It of course takes time, but you also learn from that for the next time. And to summarize what we spoke about today, then systematic reviews and meta-analyses represent the highest level of evidence in research. They are rigorous, structured, and transparent. And they don't just summarize evidence, but they identify research gaps, expose biases, and shape guidelines. And as students, it will be important for you to identify research gaps through systematic reviews because it can lead you the path to original research. So which direction do you want to go? If I hadn't done my systematic reviews on Parkinson's disease medications, I might have never come up with my dissertation research agenda that I came up with today, that I'm doing today, because I might not know that that's the problem in Parkinson's disease, where we have selective reporting. And because of that, many patients and even doctors are unaware of certain treatment and maybe, let's say, not sure if they should be used because they see that there's little trials being run on them. And eventually that also leads to a problem with shared decision making between the patient and the doctor because they cannot come up together with a good solution for the patient's treatment. And let's say also maybe the patient may have doubts because they are not sure. There's maybe not all the trials have been published, so they think it's been tried out in humans too little and they don't feel safe. So these are all things that you can identify from systematic reviews and then build a whole research agenda on, which will also involve your original research. And for you as students, it's also important to remember that a systematic review can even be a dissertation or a thesis in itself, or at least the powerful foundation of one, like it was for mine. And as I just said, it can be the launch pad for future studies, as it was with my own research journey. And by learning how to do these reviews properly, you are equipping yourselves with one of the most valuable skills in academic and clinical research or even social research. Thank you for your attention. And I know that this has been a lot of material, a lot of information that may also be new to some of you, but it is truly one of the most important areas of research methodology. And now I would like to hear your questions. And if you come up with something that maybe you don't want to ask right now, you can also email me anytime to the email address on this slide, and I will be happy to help you and answer any of your questions. So thank you.